So today I am joined by Dr. T. Lee, who is a palliative care specialist, and thank you so much for your time today to share some of your insights about palliative care. So I thought I would ask, my first question would be, how did you get into palliative care?
Well, when I was a medical student, I actually thought I wanted to do medical oncology because I was quite interested in science as a kid. And I actually did some research at Peter Mac, where I'm today as a medical student. I loved it. But when I actually became a doctor, what drew me to medicine and clinical practice was actually the interaction between doctors and patients and families. And there is a bit of that in medical oncology, but yeah, palliative care was all about that. And so I had some, role models when I was a medical student and junior doctor, and it's a bit serendipitous the people that you meet in your life, and yeah, basically I want to become like them and practice like them, and they all sort of were either palliative care doctors or doctors who spent a lot of time doing palliative care. So yeah, that's what happened.
Yeah, natural. And you're right, it can be serendipitous when these things happen. So how would you describe palliative care to somebody who doesn't know what it is?
Well, there's sort of the official World Health Organization definition, which is that it's an approach that is aimed at improving quality of life by reducing suffering in people who are experiencing a life-threatening illness. And it aims to reduce suffering in all its forms. So not just physical suffering, but psychological, emotional suffering, social, as well as spiritual suffering. But I think that definition sometimes, is a bit vague, and it's a bit hard to know how that actually applies to you. I mean, when I speak to people for the first time, generally I ask them whether they've had any personal experiences with palliative care, perhaps with families or friends, and most adults at least will have, grandparents or distant relatives or, so on. But often, that experience is in end-of-life care, and often they specifically associate palliative care with a place, with a physical location, which is often a palliative care ward or unit. But yeah, palliative care definitely is much broader than that, because it's genuinely focused on helping people to live well despite having a life-threatening illness, rather than end-of-life care. Obviously a lot of people we are involved in caring for are at the end of their life because they do have a life-threatening illness, but many of the people that we are involved in caring for are also not at the end of their life. As long as they have a life-threatening illness that they're suffering, and they would like that to be lessened, then palliative care can be helpful. So, palliative care is also not just a medical intervention, I suppose. I'm obviously a medical practitioner, a doctor, but palliative care really is a team sport. So it involves lots of other clinicians, including nursing, allied health, but also, volunteers and community members. So it's an approach. It is a medical specialty, but really the approach to care is much more important than the medical clinical aspect of it.
Yeah, that's very interesting. So as I'm a lung transplant patient myself, as I shared before, so 16 years out now and counting, but obviously I do have a life-threatening illness and short life expectancy and everything that comes along with having had a transplant. So is someone like me also going to benefit from these types of approaches, or is it more when perhaps things get a bit overwhelming health-wise and mentally that's the time I would consider using palliative care?
Yeah, lots of people have a life-threatening illness, but they're not necessarily suffering significantly as a result of that. There might be, um, you know, responding really well to their treatment. They might be really well supported by their family and friends and their medical team. And so, the amount of suffering or the quality of life is actually in their mind quite, reasonable.
Right.
So they don't they don't really need palliative care. There's nothing that palliative care would be able to add to their quality of life. But if somebody has a life-threatening illness, and that is causing suffering such that they do want some help, then, palliative care might get involved at that stage. But it's also important to, I guess, differentiate palliative care, the approach, which anybody can provide, including the lung transplant team, and they do, to palliative care as the specialty, which is the extra specialty team that sometimes gets called in to help when the generalist providers need some extra assistance. So people might benefit from palliative care, and they're actually getting it from their GP or the transplant team, and they don't actually need to be referred or access a specialty palliative care service. I think the specialist service really only gets involved when we need to.
Okay,
I suppose the other thing to say is that some people have lots of suffering and poor quality of life, but they don't actually have a life-limiting illness or a life-threatening illness. So it might be because of, social, financial, or other issues. And it's not to say that they're not suffering and that they wouldn't benefit from help, but the kind of help they need is not palliative care. They need, social workers and other sources of support. But it's really that combination of suffering and a life-limiting or life-threatening illness, I think.
Yeah. And in order to, if somebody is thinking that this is something that may be beneficial, then I assume that their special their doctors and the specialists and that would kind of pick up when it's time for maybe palliative care intervention. But if it's something they want to talk about, then that's something they bring up with their maybe lung transplant specialist, and then there's a discussion around whether, yes, this is the right time or not. And that's kind of the gateway into palliative care. Is that right?
I think in the ideal world, that's definitely the case. I think this is actually a matter of some debate and research, because I think particularly, say, in the cancer population, when they ask, cancer doctors and patients and families, they get different answers. And so the doctors are sort of saying, oh, well, I don't really want to say it until the patient wants me to say it. So they're waiting for a cue from the patient. And the patient says, well, no, I'll just wait till the doctor tells me, because they'll know when I need to know. Whereas the families in general really want the doctors to say something, because they can see what's happening, and they're prompting, but often the doctors, don't feel ready because the patient isn't ready, and the patient isn't ready because they're like, well, I don't need to do anything until the doctor tells. So, so it is quite an interesting issue at the moment that people are still trying to figure out. So
I can appreciate that from both sides. That would be also a tricky conversation too. So what are some of the other misconceptions and myths that people have around palliative care? Like, is there things that you hear and you think, oh, that's not quite right?
Yeah, I mean, we've covered many of those already, haven't we? So I think often people think palliative care is just a physical place. So, the palliative care unit. And when palliative care really can be delivered in lots of different places. So people can receive palliative care at home. So that might be a palliative care team actually visiting somebody at home. And that might be particularly, useful if somebody can't travel from home, for example. They're so frail that they're, it's a big ask for them to physically go somewhere, or they actually prefer to be at home. Palliative care have outpatient clinics, just like transplant clinics. And so that's probably more appropriate early in somebody's disease trajectory, I guess, when they probably would actually prefer to keep their home a private space rather than where people are visiting all the time. So they might prefer to come in and see the team in an outpatient clinic. So there is also palliative care consult services. So if somebody comes into hospital for, whatever reason under the transplant team, for example, and the transplant team wants some help with a particular palliative care issue, then they might ask the consult team to get involved. So so it's not necessarily just a physical place. I think the second big misconception that we've already talked about is that often people think it's just for people who are dying, within the last few days or weeks of life, or that it's just for cancer patients, for example, but it's definitely not just for cancer patients. It's definitely just for dying patients. In fact, it's really for people who are experiencing suffering, and so you don't have to be dying to be suffering,
Yeah, and that's true. You can have lots. So pain management and things of that nature, is that what you kind of implying there? Or?
Yeah, so physical suffering can be in the form of pain. It can be in the form of, respiratory symptoms, which are obviously quite common in the transplant population. So, particularly the candidates that I see, sometimes they have, refractory breathlessness, or, this annoying cough that persists and really interferes with their quality of life, despite everything that, the team is already doing. And that's when palliative care could be helpful, particularly in the lead up to their transplant.
Okay, so that's interesting. So palliative care, yes, of course, would be also involved pre-transplant. Like I've got my patient hat on, but it's something that potentially you would get involved, and then hopefully they get their transplant, and then obviously they may not need the palliative care services that they previously had in the lead up to waiting.
That's the idea. Yeah. So in the in the transplant population, we generally see two cohorts of patients. The first cohort are people who are waiting for a transplant, but and by definition, if you need a transplant, you've got a life-limiting illness, don't you? Otherwise, why would you be wanting one? And often it causes lots of suffering in terms of symptoms or otherwise. So the teams do a great job, but sometimes, people are still bothered by their physical symptoms or other things, and that's when the palliative care team might get involved. The other population are people who've had a transplant, but, either are experiencing complications of that, or, many years later, they've got a new problem, which might be related to their transplant or could be unrelated. And that might be when we get involved again. In the heart transplant cohort, we actually have an arrangement with the team where we see every heart transplant candidate as part of their workup, actually.
Okay.
And obviously, most of those patients will, go on to have a heart transplant, and we ideally never see them again, Whereas I think the volume of lung transplants that we do at the Alfred in particular makes it a bit impractical for us to see every lung transplant candidate, but we do see a fair number of them sometimes, depending on what's happening.
Well, that's right, because it can vary a lot. I know for myself, I just felt a bit puffed walking to the letterbox and was still working 3 days a week and getting on with things and not really realizing I was that unwound. So it wasn't really having a huge impact on me before the transplant. And even though I was very sick, and was obviously going to need one pretty quickly before I went downhill. But palliative care probably wasn't a logical thing for me, because I was still doing a lot of things. I wasn't in any pain. It was just a bit of breathlessness, really.
I think, Wendy, you probably were receiving some palliative care from the transplant team without it being called palliative care, if that makes sense.
That does make sense.
Whereas you probably, it sounds like, didn't need a specialist palliative care service because the transplant team were doing a good job and didn't need to refer you to somebody else, Whereas other people, despite the best efforts of the team, they need more, and so that might be when the actual specialist service gets involved.
Okay. No, that's good. Well, it's one of those things that we often talk about. there's so many different experiences of patients, of how they go through things, and what happens to one person is not necessarily what happens to others. So we're very mindful that it's very hard to say, oh, this is what's going to happen because there's just so many variables in it. So it's good for patients and their families, I think, to know that the palliative care is available when it's needed, and that obviously there's specialists like you who have dedicated their career to this area, which is really helpful. I was going to ask, now you obviously interact with quite a few of the other departments and areas, because somebody might have, I don't know, shingles and maybe some skin cancers and maybe other things which are kind of interplaying. So I'm assuming you work closely with then other departments, and it's sort of, like you said, a team sport. So everyone has their part and their role to play. Is that?
Yeah, for sure. I mean, I think you've probably heard the saying, the typical Alfred patient has 10 units involved in their care, So, we're definitely very, very much, comfortable with being part of the, many teams that might be involved in somebody's care. And I think, like I said, the most common scenario is us being sort of called in to consult on somebody who's either in hospital or in clinic for whatever reason, and despite the best efforts of the transplant team, they just need a bit of an extra help. That's when we get involved. The other scenario is when the team needs our help in coordinating with external palliative care services. So there are, obviously lots of other palliative care services outside the Alfred, and the transplant team may not be across, which ones are appropriate and necessary. And so we might get called in to just help,
if they go like
along, and
Victoria or other locations where it might be easier to get those local support services,
particularly outside metro areas. So I work at the Alfred, but I'm actually based in Albury-Wodonga. So the Alfred team probably has no idea what type of palliative care services are in Albury-Wodonga. And so if you have a patient from up there, then
at least you guys can connect. And how do you find having that initial conversation? Like I think of patients, being in the hospital and all of a sudden they're introduced to a palliative care specialist, which could maybe worry them a bit. It's like, what does that mean, that I'm now needing to talk to a palliative care person? How do you approach that sort of conversation so that people understand what your role is? And I know it
depends on the context of the conversation, right? So I think if somebody's referred because they're dying, then that conversation is very different if they're referred because their breathing's, they're very breathless. But often, I do sort of, and to be honest, I think that the transplant team is very good at doing this now. So often I don't have to do it.
Right. You're introduced.
I always do double check, just make sure we're on the same page. So, I ask questions like, why do you think you're here? What are we doing here today? And like I said before, what have they had any interactions with palliative care in the past? What's their understanding of that, what that is? And I've looked after people who are palliative care nurses, so I don't need to tell them what palliative care is. They know more about it than I do. But often people think that, maybe the team's giving up on me, or that I'm dying, and that may not be the case. It might just be, actually, no, we're trying to get you to a transplant, but your breathlessness is so bad that you can't do your rehab, and so what can we do to help?
Right. So it's how you phrase it. And that's good, and something for who's listening to this to take on board as well. The other thing I just wanted to sort of close out with was asking you, I guess, how rewarding it can be, the sort of things which, I guess you're part of somebody's journey through life, and just a little bit of insight into what that's like. And obviously you hopefully still enjoy what you do because you're still doing it. But what is it about the palliative care now that keeps you keeps you doing that? And
Yeah, look, I think as I was saying before, the thing that drew me to palliative care initially was how its focus is really on patients and families, not just a particular disease or a particular organ. So obviously the transplant team's very good with lungs or hearts, as the case might be, and you know, the actual transplant procedure and the care in the lead up to and after that. But and often that's enough, you know, and that's obviously very important. But sometimes it's people might need more than that, and so palliative care's approach to not really focus on the disease or the organ, you know, acknowledging that it's very important, but to focus on the person. You know, who are they? What makes them tick? What's important to them? Who's around them?
yeah,
You know, what are the things that are causing them suffering and you know, having an impact on their quality of life, and what can we do about that? You know, we're less worried about, you know, tacro levels or you know, what's happening with the white cell count, or what the 6-minute walk distance is, because we know that the team is across that. We don't need to worry about it, but we're much more worried about, you know, what's your relationship with your partner like, you know, how's the uncertainty around transplant, you know, affected that, you know, particularly, for example, with patients with cystic fibrosis, you know, they may have had experience with siblings or family members who've, you know, either had, you know, poor outcomes post-transplant or not being eligible for a transplant, and they might have some grief and fear and uncertainty around that. And so, you know, how is that impacting on their own transplant journey? To even spiritual concerns, which might be, you know, related to faith or religion. So, you know, why is this happening to me? Has God abandoned me? That kind of stuff. But also just meaning in life, you know, particularly in, once again, younger people who, you know, it's hard enough being, you know, in your late teens, early 20s, trying to figure out how to separate from your parents and, you know, move out into the world, let alone having to grapple with the idea of
longevity,
getting your lungs taken out and having a new set put in, you know. So so how is that going to affect their relationship with their peers, their career, all those kind of things, you know? So
sounds like it's got quite a strong link to psychology, with some of those topics that you talked about. And
that's why
I was going to say, nice segue into what you're doing now, which is your sabbatical working at the Peter Mac, which for those who don't know is the cancer hospital in Melbourne. And so that's the focus of your 6 months sabbatical, I believe. Is that right?
Yeah, so I'm embedded with the psych-oncology team. So they're a team of psychiatrists and psychologists, but they will also work really closely with the social work and the pastoral care team, spiritual care team here,
right,
to really complement the work that the rest of the hospital is doing, but really focusing on the psychological and social aspects of somebody's, you know,
and is the intent to bring some of those insights and learnings back into the transplant world? Is that kind of the plan? That'll be really interesting. I'm sure you're learning lots and also probably sharing lots of insights of your own with that. So we look forward to seeing what comes of that. So is there anything else you wanted to share that I might have missed that is important for people to know?
I think there were two things that I wanted to sort of circle back. One was in response to your question about myths and misconceptions about palliative care. I think you know, many people think that palliative care is about end-of-life care. And we've talked about how that's not the case, but some people actually think palliative care is about euthanasia, hastening death, and that is definitely not the case. And I think this is particularly relevant in Victoria now, because the voluntary assisted dying legislation was sort of introduced a few years ago, and it's just important to highlight that they're completely different, and people might or might not want to access voluntary assisted dying depending on what's happening to them. But regardless of that, if they're suffering as a result of a life-threatening illness, then perhaps palliative care could help to lessen that suffering.
Yeah.
So I think that's one important thing to highlight, because sometimes people, don't want to see palliative care because they don't think they're dying, but also some people don't want to see palliative care because they think they're going to be knocked off, and
yes,
that's not the case.
there's concern. That's like, and I imagine at that point in your medical journey as a patient, you're feeling quite vulnerable, a lot of uncertainty, and so you kind of want to make sure you have some sort of control over what is going on, and would be a bit anxious of understanding what's so that's obviously part of what you do when you explain.
Then I just wanted to sort of expand on the psychological and social and spiritual suffering aspect of it. And I think in terms of psychological suffering, emotional distress, it often is around anxiety, depression, but also grief. And so we sort of touched on this a little bit, but not being able to breathe can be quite anxiety provoking, and some people become very anxious and very panicky. And yes, psychology and psychiatry often are involved, but palliative care is also involved, I think, in treating those psychological symptoms. And I suppose grief, once again, pastoral care or social work might get involved, but sometimes if they need extra help, that's when the palliative care team gets involved. Socially, the transplant teams are very well resourced in terms of, occupational therapy, social work, and those sort of great allied health disciplines. But once again, particularly out in the community, often extra support is required, and that's when the local community palliative care team might get involved, depending on what's happening.
And that's good to know that it doesn't have to be just Alfred based, that there's other services out there that can be accessed, and particularly for those people who want to manage it from home or to be closer to where they live. And and I guess with all the technology we have with webinars and Zooms and all these things too, that they can access it in different ways as well, some of the information and support. I
think earlier on you were sort of saying maybe sharing a couple of cases.
Yes. If you're welcome to, happy to do that. That would be really good, because I think that gives it that personal touch of what you experience too as a doctor.
So I think, I'll sort of pick one case from each of the cohorts that I sort of talked about before that we commonly see. So the first case is a sort of a middle-aged lady who has, I think, advanced COPD or, pulmonary fibrosis or something like that, who was on the transplant waiting list, but was so physically frail that she had to stay in hospital and couldn't be discharged home while waiting for a new pair of lungs to arrive.
Right.
And so, you can imagine that she's in hospital for weeks and weeks with no certainty around when it's all going to end. And she became not just physically very symptomatic, but also emotionally very drained and despondent, despite the best efforts of the staff on 5 East, and
imagine
when we got involved initially, it was primarily on helping with her breathlessness and her cough, but increasingly became obvious that her mental state, her emotional state was having a big impact on her physical symptoms as well. And it was also having a significant impact on her partner, on her hubby, and how he was coping. And so working together with the rest of the ward and the transplant team, you know, we were able to improve her symptoms slightly, but really help her regain some confidence and some hope in the future, and also support his her partner in being able to support her. And then, yeah, I mean, she went on to have a transplant, and, you know, we saw them a couple of times after they got out of ICU, but we didn't, as far as I know, I haven't, you know, we haven't seen them again afterwards. So that was a great outcome.
Yeah, no, that is good. And you're right, touching on the partner, because it's one of the things we're big on at Lungitude is recognising the amount of effort that the caregiver has, contributes, you know, usually willingly, but, you know, if you're not been in that situation before, it's a huge thing to take on, to not only look after somebody, but also look after themselves as well, so they can get through it. So that's great. You guys are there to help them.
The other case that I wanted to share is a much younger bloke who also, I think he had cystic fibrosis or something like that, who had been referred for transplantation but wasn't eligible for it. I can't remember exactly what the reason was, but in addition to having cystic fibrosis and obviously end-stage bronchiectasis, he also had chronic pain, and so he had sort of complex pain issues, as well as, you know, the symptoms associated with his airways disease and the rest of his, you know, CF disease. As you can imagine, he was, and his family, his parents, were devastated that he wasn't appropriate for transplant, and so they really wanted to be able to look after him, and he really wanted to be at home, you know, and that was not in Melbourne, it was outside Melbourne. And so our role was really to get him to a stage where his, you know, breathlessness, his respiratory symptoms, but also his chronic pain was at a stage where he could be managed outside a hospital, and then to liaise with the relevant regional palliative care service to take over his care, you know, and support his family to look after him. And so eventually he was stabilized and he was able to get home. And I think he was home for several weeks, actually, and maybe even a few short months. And the local palliative care team were able to support him and his family so that he could stay at home until the end of his life. So, you know, it's not a great outcome in the sense that you obviously don't want that in a young person, but at the same time, it's also a great outcome that he was able to get home and spend all those time at home with his family, which is what he wanted, instead of being stuck in a hospital somewhere, you know.
So giving him some sort of control, I guess, even towards the end. So yeah, and I guess a much more comforting place to be, surrounded by family and friends at the
exactly
end, sitting in a hospital ward. And
we've all just been through the pandemic, so, you know, with visiting restrictions and so on. So people don't want to be in hospitals, you know, they want to be at home, because then they have more freedom to do what they need to do, what they want to do.
Yeah, and the privacy and all of the things that come with being at home. Well, I imagine most patients love the feeling of getting out, escaping, getting home, no matter what, you know, where we're at in our journey. You know, as much as we respect all the things that happen in hospitals and the care we get, at the end of the day, the whole point of it is to get us home eventually. So thank you for sharing those. And it just gives you a bit of a snapshot of, you know, both sides of that. So I imagine you have many more stories you could share, but they're very helpful to that. Was there anything else you wanted to share at all, Chi? I
think what we talked about before was just maybe any final thoughts. And I think, you know, what people might take home with, you know, take away from this video or this interview. And I think if you know, if you're someone with advanced lung disease, or you've had a lung transplant or any sort of transplant, and you feel that your health as a result of that is not as good as you want it to be, obviously talk to your transplant team, your respiratory physician, your cardiologist, or your GP. But
Yeah.
you know, if it, despite everyone's best efforts, you still feel that your quality of life and your suffering is not as good as you want it to be, then you know, it is not unreasonable to think about whether, you know, there's any other things that you could do and other people that can help you. And so whether you want to, you know, Google palliative care yourself and have a chat with your treating team, or if your treating team brings it up, don't be alarmed. You know, it's
Yeah, I
just
think
an
it's a good
extra
takeaway.
team, you know, the 11th team to the 10 teams that's already involved in your care, basically.
Yeah.
It doesn't necessarily mean that people are giving up on you or that you're dying. It's really about helping people to, you know, and their families, those around them, to live as well as possible. So
yeah, and I think that's key too, because there's one thing about getting a transplant, but you want to actually be able to be fit for life. And we use the hashtag transplant for life, because it's about that longevity, but it's also the quality of the life too. So that's, I think, where palliative care seems to play an important role in helping with that quality of no matter where you are in the journey. So yeah,
and we're definitely not sort of necessarily coming in to take over, you know, take over the whole thing. It might just be, you know, a temporary
complementary service, I guess, in a way, is it?
Yeah, I think some people call it an enhancing kind of care, but
Okay.
you know, it could be a temporary once-off or a short-term sort of involvement, depending what the issue is. It just depends on how you know what's happening, what the context is, and how we can be helpful.
Yeah. Wow. That's very useful to know. No, thank you. Lots of things I've learned in this interview, so I hope it's helpful for those who listen. And if people have got more questions, then they can certainly reach out to their I'm using the wrong word here, to their specialists, and ask for some more information. Like you said, do a bit of research into what's available. So I assume it's a referral-based service. You need a GP or another doctor to refer to palliative care. Is that how that works? You can't just go direct?
Yeah, once again, it depends on the context, but I think for transplant patients, the easiest thing is probably just to speak to their transplant nurse or doctor, and they can sort of have that conversation, because it may be actually that you don't need a referral, that actually the transplant team will just say, okay, well, we could just get the ball rolling and try X, Y, and Z.
Sort out an appointment. Yeah. I guess it's a good starting place for people to learn some more general things about it, and some of, like, the myths and misconceptions has been really helpful, and some of the stories you shared as well, to give some examples. But I think that will be very helpful. So thank you again for your time. Very much appreciated.
No worries. Yeah, thanks for the opportunity, and hopefully it's helpful.
Yeah.